got a lot more replies on the survey that we asked for. We have only 11 trusts outstanding now, so thank you to everybody that has completed that for us. And if you are one of the trusts that Amanda's still chasing, we would really appreciate it if you could send your response back to us. Do appreciate that it's holiday times, that might be why we're still outstanding a few. We've got 5 sites that are interested in signing up with us, which is absolutely fantastic. I just wanted to reiterate 2 sites that if you needed any site visits or telephone support or any help on anything, then if you can get in touch with myself, then we can sort that out for you. In terms of future webinars, we're constantly seeking volunteers to speak on any topics that you might wish to share with us, sharing work, best practice, etc. So if you could get in touch with Amanda with anything that you would like to contribute, that would be fantastic. And also not to forget that if anybody does have any particular issues or topics that they'd like to discuss to gain help from other sites, etc., then we can also cover that on these webinars. And lastly, we do have Alison Crawford from our measurement team on the call, and if anybody has any measurement questions, we can cover those at the end in any other business. But also, if you wanted to put something into the chat that Alison could perhaps answer whilst the WebEx is taking place, we can also do that. Okay, that's all I've got to say. I've rattled through that a bit to try and catch up on some time. I'd now like to hand over to Katie Lindsay, who's works in Public Health England, who's going to talk to us about end-of-life care data collection. Okay, thank you, Lindsay.
Hello. Oh.
Hello, Lindsay.
Hi, thank you.
Katie, we can hear you.
Right, thank you very much, Debbie, and good afternoon, everybody. So, as Debbie said, I'm very pleased to come and talk with you this afternoon. I primarily wanted to tell you about a new national data collection and the plans we have for that. Are my slides available? I can't see them at the moment.
They are on the screen, Katie. You should have now those presentable.
Okay, I can't see them. Should I go forward? Oh, yes, I've got it. Right, sorry, my apologies. So, excuse me, everyone, for any technical issues, but I think it's going to be very easy, and I'm going to do my best. So, just getting started. So, if I move forward, right. So, before I tell you about the new data collection, I just thought it might be helpful to give a very brief overview of the intelligence network. Hopefully, all of you are aware of the network that was established in 2010. And in 2013, we moved into Public Health England, and we're now one of 5 intelligence networks that sit in the Chief Knowledge Officer's Directorate. So we have a whole range of resources that are available to support our stakeholders, all freely available on our website. And these do include end-of-life care profiles for each CCG and local authority in England, plus a range of reports and tools and resources. I do appreciate that we don't have anything at the moment published on reporting at acute hospital trust level. We may well be able to do this in the future. We should be able to we are going to get access to a new data set which is linking ONS mortality data with hospital data. And there has been delays in us getting access to this information, but once we have that, we should have more ability to be able to report at that level, which I'm sure will be very helpful to you. Right, but we do have a lot of data on end-of-life care in England. This includes, as I say, our main data that we use is mortality data from the Office of National Statistics, which is based on death registrations. We also report quarterly on proportion of deaths in usual place of residence, and this is by CCG and local authority level. And coming soon, we're going to be adding further nuanced information that will actually give the proportion of deaths in each location, hospital, care home, hospice and home. So, and that will again be by local authority CCG Strategic Clinical Network. So we hope that will be very valuable to you. The linked HES ONS data, as I said, is what we're waiting for at the moment. Other national data that you should be aware of that is produced is the Voices National Survey of the Bereaved. You're probably aware of the End-of-Life Care Audit, dying in hospital, that used to be called Care of the Dying Audit. There's the national collection from Specialist Palliative Care that's captured by the National Council for Palliative Care, NCPC. And there is a community information data set which captures information and reports on community care. So there is a lot of data there. When we think about specialist palliative care, though, we are limited to the national survey carried out by NCPC. And this is an aggregated data collection. So, it's captured on an annual basis. It's very valuable and gives us a lot of important information that we wouldn't get in any other way, especially as a lot of care delivered, specialist palliative care is delivered outside of the NHS. So but there are limitations on this data as it is in an aggregated level, and that the response rate is at the moment about 65%. So that means when we try and ask the question, how well do we die, across all areas really, we have got some limitations on being able to answer that question. There's some things we know. We definitely know how many people are dying and where they're dying and what they're dying of, but we don't really know how many people need specialist palliative care, and we estimate that. We think that around 33% of people that are dying probably get it, but our understanding as well of the quality of the services and how they integrate and what is the actual outcome of the interventions that are provided, we really have very little information about that. So, there are real gaps in our understanding of how end-of-life care is provided and what the quality of that care is, and what do we mean by quality. I've sort of been working in end-of-life care for 6 years now, and I'm sure, like you, there are a lot of questions I have that I'd like to know the answers to that are very difficult to find the answers. And so these are some of my questions, and I expect you may have some of those and some different ones that are difficult to answer at the moment. When we're looking at quality, we're really limited at the moment to thinking about some proxy indicators that we have, things like the Voices survey, which is asking the bereaved for their views on the quality of care, and then our death in usual place of residence, which again is only an assumption really, as we know that more people prefer to die at home, but it's not specifically matching the people's preferences to where they die. So there are limits there, and we can't answer a lot of these questions at the moment. So I'm not sure if you are all aware, but you may well be, but NHS England has been working over the last few years to develop a new funding mechanism from specialist palliative care services. And that started from the palliative care funding review that we reported in July 2011. And NHS England ran pilot sites across the country between 2012 and 2014. And those completed and had recommendations for some development currencies, which currencies are ways of grouping healthcare into units that are clinically similar and have similar resource needs, and so that they can be used to support commissioning of specialist palliative care services. So that funding system also requires data at an individual level to support it, and these development currencies require information about the age of people, how many diagnoses they have, the phase of illness, which there are 4 phases that they use: stable, unstable, deteriorating, or dying. and also the functional status of an individual, and that's based on the Karnofsky performance scale. So that work is underway at the moment now to test those development currencies. So they're testing them further to ensure that they're workable, meaningful, and identify any changes that need to be made. And the ambition being that they will be used to support commissioning going forward. So this seems a really good opportunity for developing a new national data set from specialist palliative care, because we thought, as with that requirement in the background, we could look to develop one single data collection that would capture information on demographics of individuals, the activity and the outcomes of care, but also support a funding system. So what we're looking for is a data set that will be able to give us better information about how many people are actually referred to and receive this care. We hope it will support integration of care between different providers. We can understand how people are moving between different services. We'd have, for the first time, a way of measuring effectiveness of palliative care, and give us a way to compare how different types of care, what is the impact of it, and is there variation in the outcomes. So this, we would hope, would support commissioning and service improvement, would help to be able to reduce inequalities, and see it as a way of driving up quality and cost effectiveness, so that ultimately we should see, this power of data being able to support and improve the quality of care for people and their families. So this model you can see in front of you now shows how we expect the data to flow. In your top left-hand corner, you see the patient and a sort of bubble there, and this is the patient clinical record. So what we are looking to do is to make this data set to be a part of the normal clinical data collection. It would be a subset of that. And the little bit orange C that you see there would be the part of that data that's required to support the commissioning of specialist palliative care. So we would be looked to collect individual level data into a secure national data store, which may be in Public Health England or perhaps the Health and Social Care Information Centre. And that would all be controlled, security, complying with all NHS regulation for data handling. And that would enable us to do analysis and reporting and be able to then report out to the provider sites themselves and provide some summary reports that we would see would support clinical audit and evaluation of services and support improvements. There would be some national reports that we would expect Public Health England could publish on our website, and there would be opportunity to use that data with the right controls, perhaps for research and other uses with permissions to start to build the evidence base. And then if you look at that sort of green arrow coming to the right too, that little section of data with the orange C, that section would be submitted to NHS England to support them to provide data to the commissioners to support them in commissioning specialist palliative care. So that's my sort of diagram, which I hope you followed. So what have we done and who have we involved? I mean, this is quite a big project, and we very much appreciate that we need to work with a wide number of stakeholders, and we really have involved a lot of people to date. Public Health England is working in partnership with NHS England on this, and we have a steering group that has got all of the statutory bodies that you see listed on your page here involved in our steering group. This is chaired by the National Clinical Director of End-of-Life Care, Dr. B.U.E. We also have an expert reference group chaired by Dr. Sarah Cox, who is from the Association for Palliative Medicine, and we've got good wide representatives on that expert reference group, and we have engaging with pilot sites too. And the expert reference group includes the voluntary sector representatives on that, as well as clinical bodies and provider sites. Sorry. So the principles that we have on developing our new data collections is that we wanted to build on existing data already, and so as I said, it is part of the normal data collection that we expect to be underway. We wanted the data set to start small and see that would be better rather than being too ambitious. We want to be able to link it to other data sets in the medium to longer term, and so it is going to be individual level data. We're going to incorporate validated outcome measures so that these have been thoroughly tested for capturing outcomes in specialist palliative care, and that we see would have the sector would have confidence in. And in order to ensure that we've got robustness of this data collection, we're developing a national information standard to support it, and are working with a standardization committee for care information to do this. And as you will realize, it's very important that we can make meaningful comparisons because in order to take account of case mix. So we're going to benefit from the work that's already been undertaken in the palliative care funding team and with the OAK project in looking at case mix factors, and we'll be building this into our analysis. So we have already probably in our second year now of the project, and we have done quite a lot of work to date. We have been promoting and consulting with stakeholders with NHS England around the country, and I'm hoping that most of you will have already heard about this work in some way. We are at a state where we have got a draft data set agreed now for testing and national consultation, and that data set is aligned with the palliative care currency data requirements, and also aligns with the OAK, the Outcome Assessment Complexity Collaborative data set. And we are in process of developing an information standard, as I said. We ran an online consultation in March 2018, 15 this year we ran it, and we had 163 responses to that. 75% of those people felt that it would had the potential to improve care and drive service improvement and better use of resources. We have also, very recently, just this month, we've run 2 focus groups with patients and the public, and I haven't yet really got the feedback from that, but my understanding is that there was support from them for having a new data collection too. We've been working with IT systems providers to help get them to help us to be able to collect that data. One of our biggest challenges with this sector is the large number of IT systems being used in specialist palliative care, and also, there are not a few service providers that don't have IT systems at all, and in acute hospitals that this could also be a problem too. So we're working with them to help resolve that. And testing is now underway with our pilots, and we're supporting those pilot sites. We've also supported the pilots with offering them some training, some resources to support them in training on the outcome measures, collecting the outcome measures. So our pilot sites that we have are listed here. We've chosen sites to give a good range of different organisations. So we've got a range of hospitals, hospices, community sites. We've got geographical spread, different types of IT systems, and different capabilities and experience in IT and in capturing outcome measures. So you'll see there are a few hospitals in that. And this is a summary of the data set that we'll be collecting. I realise we're sort of getting short on time, so I'm not going to be able to go through all of that data set with you, but in the right-hand column, you'll see that there are these are the assessment data items that will give us the outcomes and be able to assess outcomes and captured over different time points to see changes. So they include the Karnofsky functional status and some measures from IPOS for pain, breathlessness, at peace, anxiety, information needs. There's a question from St Christopher's Views on Care, and there are 2 questions to assess the impact of care on carers themselves. So one is based on the skip question 2, and one is from the picker and voices question on their assessment of how adequately well supported the carer feels. So that's a look at the data set, and we are asking data to be collected at first assessment and then at change of phase. So the way that the structure is for data collection is based on spells of care, and phases the same as the palliative care funding system, being based on phases of stable, unstable, deteriorating and dying, and these are all very well defined and have been tested. So we'll be capturing data at the beginning of a spell and at phase change. I probably don't really need to go through that. I'm going to skip that one really, but you may look at it later, and it just shows the interaction between our piloting and the NHS England funding pilots and how they relate. But I'll move on to next steps. Our pilots are running until March 2016. They're going to be capturing and submitting the data for a minimum of 3 months on monthly submissions, and we're hoping that will start in September. We will be working with them to evaluate the collection and what the impact and burden of the collection is for them. We'll be looking to see what revisions need to be made. We're also developing and testing a web-based data entry tool that could be used by sites that don't have IT systems. Communication is an important area for us to make sure that people are aware of the plans and what it means for all of the sector. So we will be putting a plan in place, and we have just launched yesterday, and I invite you all to go and visit our website and view the web pages, because we've got some new web pages up with information about the plans for data collection, and we do plan to publish a new update statement for that will be published in September too. We're still working on our information governance and legal framework, and as I said, we are working towards publishing an information standard, which we aim to publish in June next year. Then, as the results of the piloting, we will be continuing to work with NHS England and look at how we're going to work to implement the rollout and going forward, but we're planning to have a national rollout by April 2017. So I think that's about it from me. You can find out more about the project on our web pages. As I said, there was a joint statement published in September last year. Do visit the web pages, and to introduce our team that's working on this project, we have Malcolm Roxburgh, who is our project lead, and Helen Bolton is the project manager. We really welcome any comments and suggestions from you, so please do get in touch with us. And also a last message for those of you that we do encourage everybody to please continue to submit MDS returns. In the longer term, the MDS won't be required, but at this time it's especially important that we have that data being returned, as it helps to justify, validate the need for national data. And at the moment that there's a lot of people that rely on that information. It is important data, and we don't have anything else at this time. So I think that's it from me now, and if there's any time for questions, I'll hand back to Debbie. Thank you, Debbie.
Okay, thank you very much, Katie. We are overrunning a little bit, but if anybody's got any burning questions that they'd like to ask, we could squeeze in a couple. So I'll just hand over back to Sandra to see if anyone's raised their hand.
We haven't got any questions actually in the chat box at the moment, so if you do have a question, do feel free to type it in as we speak. If you do have a question you want to ask yourself, then just click on the hand icon in the participants panel and we will find you and unmute you. I'll just give you a couple of seconds to do that now if you've got a question for Katie. Okay, it doesn't look like we've got any hands at the moment, but there will be obviously another opportunity at the end of the session. If you do have any questions that you want to ask, do feel free to put them into the chat box. And we're now going to move on to Deborah Borrell. We are just going to locate Deborah, so please bear with us a few seconds while we just try to locate her.
Hello.
Hello, is that Deborah?
Hello. Hi. Yes, it is.
Hi, can you hear us?
I can hear you. I can't see you or any of the slides, but I can hear you, so I'm just on the phone only. But I do have the slides of mine in front of me, so if we can do it that way, I'm happy to do that.
Okay, no problem, Deborah. If you just say next slide when you're ready, and we'll move the slides on the screen for you.
Yeah, that's fine. No problem. Thank you. Am I okay to start? Sorry.
Carry on.
Okay, hi, I'm Deborah Borrell and I'm the Palliative Care Discharge Facilitator for Leeds Teaching Hospitals. And I'm hoping just to share some work with you that we've done within Leeds to support dying patients to achieve their preferred place of care. I only have a few slides which I'm hoping will prompt some conversation and I'm happy to answer any questions. Next slide. So you should have the rapid discharge plan in front of you there, hopefully. And this is one of the documents that we've developed within Leeds to support the nursing staff to be able to transfer a patient safely at the end of life. Not only will it guide their care, but it would also... This is now out on all the wards, hopefully, at Leeds Teaching Hospitals, and will support the nurse to transfer patients who are very much at the end of life and wanting to go to usual place of residence or home to die. There is a flow chart within here that helps them with decision making. So if they're unsure whether the person actually is rapidly deteriorating, have they had conversations, is the person and the family aware of what's happening now, they can actually go through a certain flow chart before they actually start the documentation. And then it has very practical sessions within there that are around communication. What should they be saying now? Have they had these conversations that are obviously extremely important, maybe around DNA CPR or around where the person is actually at this time, and what are the family's thoughts and what are the preferences of the person. It also there's fast-track funding within there, so if they're unsure how to go about the process of discharge, it should help them. Talks about care planning meetings, so what do they need to do within the care planning meeting, what should they be assessing, what do they need to say, what do they actually need to be doing as a nurse. And then there's a discharge checklist at the end which will take them through, have I done this and what else do I need to do. Next slide. Should be the supporting leaflet. We developed a leaflet to aid a conversation, so not to just give out by itself, but obviously to support a conversation with the family and carer. And we have a bereaved carers group in the palliative care team here, and we had some feedback from the people that were part of that said they felt very alone when they'd gone home, especially if it's been a rapid discharge. There may not have been time for a care planning meeting, and they were unsure of who was going to be there now to support them, any contact numbers, and actually who would be coming into the house now they were at home. So there's a space on there for the ward to add any essential contact numbers for the community and for the ward as well, and also any out-of-hours numbers, so palliative care emergency helpline number. Next slide. We have an intranet site that we've developed with our palliative care team, which I believe is being used quite widely across the trust, and anybody can access this. And not only will it tell them all about the palliative care team, who to contact, what to do, it has a whole menu of different things in there of care of the dying patient, rapid discharge home, ambulance details, medicines management, social work, and any training. Within the discharge section, they have a flowchart which will take them through a rapid discharge, and they can link to any documents that they may need on the ward. So if they've got to a certain point and think, I don't have a fast track document, I don't know where that is, where do I get that from, they can click on this flowchart and print the documents off. Next slide is the palliative care ambulance, and we're very lucky in Leeds to be commissioned to have a palliative care ambulance, which is a dedicated ambulance for palliative care patients. And this ambulance is every day, 24/7. They can book. It will actually run from early in the morning till around 7 at night. We have 2 crews now, and we can transfer palliative patients that are going to preferred place of death, but also patients that may need to go for urgent treatment or maybe coming from the hospice back into the hospital and require a emergency palliative care treatment, really. And there's just the next slide, which is on the palliative care ambulance again, and that just gives a few more details if anybody wanted to see those of how the ambulance works. And this poster would be on all the wards for everybody to kind of be able to access and to tell them about the service. So that's just a very quick overview of some of the things that we have within Leeds, and I'm open to any questions if there is any.
Thank you, Deborah. We haven't got any questions in the chat box at the moment, so again, if anybody does have anything they want to ask of our speakers, do post them in the chat box and we will pick them up. If you've got an urgent question now, you can just click on the hand icon and we will pick that up and unmute you so you can ask your question. Okay, we've got no hands at this stage, so we'll move on to back to Debbie Barnhurst. Oh, apologies to Linda.
Hello there. Can you all hear me?
Hi, Linda. We can hear you.
Lovely. Hi. So yes, as you see, my name's Linda Launchbury. I'm one of the palliative care Macmillan nurses at Peterborough and Stamford hospitals, and we have introduced the Amber Care bundle with the support of the Amber Care network within our trust. We are a large district hospital with just over 600 patients, and from the 1st of April 2014 until the 31st of March 2015, we had a Band 7 Amber Care bundle facilitator with the view of rolling out the Amber Care bundle across our 19 wards. And that we have done, and I'll share with you now some of our experiences, some good things to report with our audit, but also the concerns and issues that we have. Okay, so I'm sure most of you are already familiar with the Amber Care bundle itself, but for those perhaps not using it in clinical practice, just a reminder that it's a simple tool. It's one of the 5 drivers for improving end-of-life care advocated by the National End-of-Life Programme. And it's aimed at improving quality of care for those patients whose recovery is uncertain, but whose prognosis may be as short as 1 or 2 months, and they may still be receiving active treatment. Up until the end of June this year, we've supported over 1,000 patients with the Amber Care bundle, and it is used on all adult wards. So again, some of you, or most of you, will be very familiar with this, others maybe not so familiar. So just a little reminder or an overview of what the Amber Care bundle entails. If we identify someone in the first box, if we identify a patient who we believe should be supported by Amber Care, they're clinically unstable with limited reversibility, can be any diagnosis, but we also believe that they're at risk of dying, as I say, in the last 1 to 2 months, then we can support them with this tool. And it supports best practice. Day 1, we would identify the patient and print this off our e-track system within the hospital, and then we would be making sure that the patient has a very clear medical plan, including a resuscitation status, and where necessary, the form completed promptly. We'll ensure that there's a clear escalation decision so that if our patient deteriorates overnight or over the weekend, we know what the plan is, and the patient and family know what the plan is, whether that's ward-only care or whether they would progress to HDU or ITU. Of course, the third grey box, so it's really important that the medical team and the nursing team agree with the plan and that everyone is involved and there's continuity. And most importantly of all, that discussion with the patient. So this prompts that really important patient-carer discussion. And I know in hospices this happens routinely, automatically, but within a large acute hospital where palliative care isn't the #1 thing on everyone's mind, this is so important that we support our teams with really good practice. So this helps to focus people on what's really important at this time, ensuring that we talk to patients and carers about their wishes, their preferred place of death and care, and any concerns they have and any needs they have at this time, so we do our best to address those. This would be day 1, and this would be discussed, as I say, with patients and carers and documented in the notes. Then day to day, we would have the orange labels that just prompt us within our assessments to think about, is our patient still at this stage, or they improved or deteriorated and maybe need end-of-life, more individualised care plans? And have we touched base with the patient and carer? Have we given them an update and a chance to express if there are any concerns or any new wishes, including the preferred place of care where that's changed? So apologies to those that are very familiar with this. So we have in fact now rolled out AMBER to all relevant staff. So by that we mean over 90% of the nursing staff received training, and some of the bank staff, which is quite a tall order because we have quite a lot of bank staff on our books as well. As I said earlier, we've supported over 1,000 patients now with the Amber Care Bundle, and it has shown within our audit to reduce readmissions into hospital within 30 days of discharge. Our baseline before supporting with Amber Care in the Trust was 40% readmissions into hospital within 30 days of discharge for our end-of-life patients. And that, of course, now has been reduced to 5% readmissions. We've also increased our patients achieving their preferred place of care. The baseline was 20%, which was abysmal. And within one of our audits, we achieved 85%. Sadly to say, that has dropped slightly, 73%. So still better than we were doing, but we are doing all that we can to improve that again. So I thought it'd be quite nice to have a patient story. One of our ladies, Betty, was admitted from home following a rectal bleed. She was treated actively initially, and then on investigation, they found she had a large rectal mass, metastatic spread. Surgery was ruled out as not being an option, and the plan was best palliative supportive care. She was already being cared for in bed on her admission. So we had discussions with Betty and her husband Arthur about her preferred place of care, where she'd like to die, her wishes around resuscitation, and we discussed an escalation plan in the event that she deteriorated. Now, Betty and Arthur both wanted her to be at home, so fast-track funding was agreed and cares put into place, although we only managed some nights because of capacity, sadly, and twice daily cares. The Amber Care Bundle, of course, part of it is making sure that we're communicating well for that continuity of care, so that when the patient moves from our hospital to the community, we want the communication to be as good as it can be. So on our GP letter, we have got a drop-down box that we can select if our patient is supported by the Amber Care Bundle, and that alerts the GP to the fact that our patient is supported with the Amber Care Bundle, and then prompts us to answer some questions regarding resus plan, escalation plan, does the patient need anticipatory meds, and the preferred place of care, and a brief outline of conversations we've already had, so that the GP will know what's happened so far and be able to build on that. And we've got a similar system now with our district nurse and community mat nurse referral forms. There's a drop-down box that we can select that then goes on to prompt us with these things, so that we can share that really important information. So the outcome was that Betty did die at home 5 days after discharge with her husband at her bedside. And he was really pleased to report that he'd pureed his own homegrown raspberries for her, which were her favourite. And she only managed a few spoonfuls, but he said she enjoyed it very much. So how does the Amber Care Bundle work in practice? Well, we identify patients within our wards that are clinically unstable, they're deteriorating, they may or may not be having treatment at this time. They're at risk of dying, we believe, within the next 1 to 2 months, and there's limited reversibility. So perhaps whereas previously we would have cared for our patients, adapted their care plans, and then maybe gone straight to the end of life, the last few days care plans, this is all about us identifying people that bit earlier so that we give them time to adjust to what's happening and to think about what are their wishes, and to give us time to hopefully achieve that with them. And on a practical level, we print off the Amber Care Bundle from our hospital e-track system, and this prompts conversations with the family. So this means that even if the palliative care team are not involved, hopefully this will prompt best practice. We also have the Amber magnets on the whiteboard, which identifies, at a glance, which patients are supported by the Amber Care. So issues that we are having within our hospital, as I say, the Amber Care Bundle facilitator was a year-long post. Sadly, we didn't secure funding to carry that on, but we are in the process of putting forward an investment appraisal. It's been delayed for various reasons, but we are pushing forward with that, hoping to link it into a post that supports breaking bad news to junior doctors, something that we've for a long time felt they need much more support with. So particular problems we've had, and I'm sure other trusts will be identifying with this, sometimes we find that wards identify patients, print out the Amber Care Bundle, maybe have a resource decision, maybe have an escalation decision, but then don't take place, the conversations don't take place as to preferred place of care and patients' wishes. And we suspect there's a number of reasons for this. Sometimes it's the perceived lack of time of the team, we think. Sometimes we feel it's perhaps the confidence, if it's a junior doctor who's not used to having these conversations. There are various reasons. Another thing that we find is that the teams don't always call the GP surgery if the palliative care team are not involved. We have regularly requested that teams do this, that when someone is being discharged home for end-of-life care, that we do phone the GP, not just do the electronic discharge letter. We sometimes find that doctors do not complete the Amber Care Bundle section of the discharge letter, and when prompted, they say no, the patient is not supported by Amber, where our audits have shown that sometimes that's not been the case, and they could have given more information. And sometimes we find that patients are not identified at all, and therefore Amber is not started in the first place when we do sort of spot checks, or if we're on the wards and we pick up there are patients there that should really be supported by this. So there are issues. And we are doing our best to get around, and the palliative care team have a number of wards each that they try to attend the whiteboards. We're spread thin these days, like lots of people, because we've moved to a 7-day service, which is fantastic. It means someone's on call at the weekend to reply to palliative care issues, but it does mean we're spread thinner in the week. But we push on with our education, nurses, doctors, inductions, regular updates, and support the staff as much as we can with role modelling, etc. But as I say, we are in the process of trying to secure funding for a substantive post. So I'm aware of time, I'll try and speed up a little. I'll just share with you our audits. Our baseline audit in July 2013 was before Amber Care Bundle was introduced, and it was of 20 patients. 10 who died within hospital, and 10 who were discharged and died within 100 days. We then followed up with 3 audits in January 2014, July 2014, and this January, and that was with a retrospective review of notes of patients who were supported by Amber Care. Sorry. So the blue section is before Amber Care. 60% of patients only had an escalation plan, and this was increased to 100% the first re-audit. It went down sadly to 90% and then back up last time to 100%. Similarly, patients with a DNAR decision, 70% before Amber, that went up to 100%, a dip slightly to 95%, and then back up to 100% in January of this year, so an improvement there. The known place of death, before Amber Care Bundle, we only knew the place of death of 40% of our patients, which was abysmal. And that went up the first audit to 65%, then up to 90%, again a slight dip to 83%, and this is knowing the preferred place of care. In actually meeting the preferred place of death, the baseline, we were only meeting the patient's preferred place in 20% of cases. This initially went up to 40% and then up to 87%, and now the last audit it was 73%. Nearly there now. Readmissions within 30 days of discharge. Before Amber, 40% of our patients that were at the end of life were readmitted within 30 days of discharge. The second and third audits showed just 20% of patients readmitted. And I'm pleased to say the very last one showed that just 5% of patients were readmitted, and the audit was slightly bigger, you'll notice. The last audit was 30 patients, whereas the 3 subsequent audits were 20 patients each. So that's where we're up to so far. We are due to re-audit, and I'll keep you posted with the results. Do you have any questions at all or comments?
It's Debbie here, Linda. Thank you so much for that presentation, and it's really encouraging to see that you've managed to make such a lot of improvements by using the Amber Care Bundle. And it's really great that you actually have had baselines to start off from, so you could actually demonstrate where you've got to. So that's absolutely fabulous.
I'd like to just, what I should have said was that I'd like to acknowledge all of the support we've had from the Amber Care Network, because of course all of the audits we have carried out have been based on the templates from the Amber Care Network. So Susanna Schultz and her team have been so supportive. So we can't claim the credit for designing the audits, but they've been a great help in helping us to achieve what we've achieved. So I must mention them.
That's fabulous. And I know Susanna is on the webinar, so I don't know if Susanna wants to say anything.
I just thought I'd let you know, this is Amanda, by the way. We've just had a question come through from Susanna, and she's asking, Linda, what feedback have GPs given you on the feedback you are giving them, if any?
When we've gone to GP jamborees to speak, they've been very positive, and they've fed in. For example, they helped us shape the GP letter template, you know, the drop-down boxes for Amber. Initially, we got feedback saying that they hadn't heard of it, but we knew that we had put a lot of information out there on our intranet, extranet letters, but I think it's very difficult. So much information comes through, and you can't guarantee that everyone reads everything. So what we did do as a result of that feedback was, on the GP letter, the Amber Care Network website is there, so that if they're not familiar with Amber Care, they can look it up. I'll be honest, the feedback back, apart from they're always very grateful when we speak at the jamborees, and they've invited us to several things, which we see as a positive step, but we don't very often get feedback back. So I think it would be ideal to have more time to explore that, but it's very difficult at the moment. So I think we sort of think, well, no news is good news. But we do tend to sort of take very seriously the feedback that we get to see if we can improve it. So I think no news is good news, really. And if we do get a substantive post, that's one of the things we'd like to develop more.
Thank you, Linda.
Thank you.
Debbie, would you like to start the AOB? Yeah, I just wondered if anybody else has got any more questions they want to ask, or whether anyone wanted to have a discussion on anything that we've heard. I know everybody's muted, but if anyone wants to raise their hand, if they did want to offer anything, then that would be great.
We've got no hands at the moment, Debbie, but we'll, you know, we're keeping our eyes peeled for them.
Okay. So now then, it's just if anybody's actually got anything else they'd like to talk about, or any questions for Alison, who's on the call from our measurement team. If anyone's got any measurement questions, again, if they want to put something into the chat box or raise a hand if they want to actually say something. Everybody's quiet today.
No, we've still got no hands up at the moment.
No? Okay. Well, if nobody's got any questions, I think that we could probably finish a few minutes early, which is quite a good achievement considering we were running late at one point. Again, if I can just reiterate to those on the call, and if you want to discuss with colleagues, if there is anything you'd like us to cover on these webinars, then please let us know, and we'll do our best to do that for you. But thank you for your time. The webinar is recorded and will be sent out to our Transform sites so that other colleagues can hear these excellent presentations that we've had today. And lastly, may I just thank Katie, Deborah and Linda for spending the time and for your excellent presentations today, which were great. Okay, thank you everybody.
Thank you.
Bye-bye.
Thank you.
Bye.